Great, thanks David for the opportunity to talk today. I noticed that when you invited me, you didn't tell me who my debate counterpart was going to be, and had I known that, I might have thought twice about it. So I'm going to be talking about molecular genetic testing and whether it should be done routinely in people who have unexplained cytopenias, and I'll obviously make the argument that we should be doing this. And actually, let me start with my disclosures. I do work for a couple of companies that make genetic tests that can be useful in this setting. So I want to set the parameters of the debate a little bit. I want to talk about what we're actually talking about. So I was asked to discuss the yes position, and Gail was asked to talk about the not yet position. It wasn't no. It was that maybe we just need a little bit more information, or there's some data that we're missing that will help us make this decision. So I'll argue that we have that data today. And then what do we mean by routinely? Are we going to be doing this in every patient or just certain scenarios? And I'll talk a little bit about some different scenarios in which I find this useful. And finally, it's important to talk about what kind of genetic test is involved here. Some genetic tests are very limited. They include just a handful of genes, while others can have 20 or 200 or even a whole exome, and they have different levels of utility. So finally, I'll share with you a little bit about what else you can learn from mutations besides the help that they might provide in establishing a diagnosis. So let's talk about first this diagnostic use of mutations. So we have done a really good job of using mutations to help identify the myeloproliferative neoplasms. In fact, the associations between mutations and diagnoses are so tight that we've actually rewritten the diagnostic criteria for several of these disorders to include mutations. In AML, we've done something similar where we've actually gone away from a more morphologic classification to a much more genetic and molecular one. And in fact, very recently, did this with an incredible degree of granularity, suggesting you needed to look at a large number of genes in order to really be able to classify AML into different subgroups. And we could certainly do something similar with MDS. But in anticipating some of Gail's points, there are some potential problems with mutation interpretation in MDS. The first of these comes from the fact that normal individuals have a really high incidence of somatic mutations in genes that are very typical of MDS. In fact, that rate approaches 10 to 15% when you look at 70-year-old people, people who do not have any hematologic disorder and in fact have a very, very low risk of ever developing a hematologic disorder. So this is the background that we're dealing with when we look at patients in our clinics and ask whether the mutations that we identify have any clinical significance. But if you look closely at the mutations that we find in these normal individuals, this condition that we call clonal hematopoiesis of indeterminate potential, or CH.I.P, there are some features about them that can distinguish them from patients that we think are at greater risk. So one of these is how abundant those mutations are. These plots here from two different studies show that the mutations that we see in normal individuals tend to be relatively low abundance. That is, they're only responsible for about 10 to 20% of all nucleated cells in the peripheral blood. They're not overwhelming the number of cells or suggesting that there isn't any polyclonal hematopoiesis left. Now, what happens in patients who truly have a cytopenia? These are the patients you're more likely to be seeing in clinic. So we actually participated in a clinical trial where 144 patients thought to have MDS by their physician were subjected to a standard hemopathologic workup, and then were put into one of three bins: definitively MDS by morphologic criteria, some elements of dysplasia but not enough to make the diagnosis, and then patients in whom the pathologist said there is no evidence of MDS whatsoever in the marrow. And we sequenced these patients for just 22 myeloid malignancy genes, and this is what we found. We found that in the MDS patients, there was a clonal marker in almost every single case. There's only one patient who on this limited panel we couldn't find a clonal marker. Yet for those people who had some degree of dysplasia, shown here in blue, 71% of them had a clonal mutation. So substantially higher and very close to the MDS number. But even in those individuals that had no dysplasia whatsoever, these cytopenic patients who were otherwise unexplained, we could find a clonal marker, a mutation, or a chromosomal abnormality in 27% of these patients, about double what you would expect in that background rate of normal individuals. So we have called these patients here who fall short of the MDS diagnosis as having ICUS, or idiopathic cytopenias of undetermined significance. And by doing mutation testing, you could actually divide this group into a subset, about 35%, that have clonal cytopenias of undetermined significance. And we think that these are the patients that are at higher risk, and I'll show you the data that I think will help us make that determination. Now, we went back and added several additional patients in a retrospective manner to kind of fill out the numbers, and if you look at the patterns of mutations in patients who have unexplained cytopenias with mutations, they have a few differences from MDS that I think are important to point out. First of all, some mutations like SF3B1 are much more common in these patients who definitively have MDS. And while TET2 and DNMT3A are more common in these patients who don't have a lot of dysplasia, the frequency with which we see these mutations is much, much lower than the frequency with which we see them in normal individuals. So they're not like that background population. Many of the more adverse genes are starting to pop up here, like TP53 and SRSF2 and so on. And then most importantly, the abundance of mutations that we see in these patients with cytopenias is high. They're responsible for, on average, 40 to 60% of hematopoiesis, not that 10 to 20% that I mentioned in older individuals with CH.I.P. And in fact, many patients have almost complete replacement of their bone marrow with clones defined by these mutations, and they look a lot like the patients who have MDS. So they're hard to distinguish from MDS just based on the abundance of mutations. Now, there is one place where the WHO has said you should do mutation testing in the diagnostic evaluation of MDS. And these are patients who previously would have been considered to have ICUS because they didn't have enough ring sideroblasts to meet the definition of the disorder. But now, if they have at least 5% ring sideroblasts and an SF3B1 mutation, then you can call them MDS with ring sideroblasts. So here's a situation where it's actually in the guidelines that you should be sequencing at least one gene. And the reality is that if you're sequencing one, the cost of sequencing 2, 5, or even 20 isn't dramatically different and potentially valuable given all the other information it might give you. So what is the evidence that these patients who have unexplained cytopenias, don't meet the diagnostic criteria for MDS, actually are at risk of anything? And a paper that was published in parallel with ours looked at this question by looking at patients who had a non-diagnostic biopsy that later progressed to either MDS or AML. They found 69 cases like this. And their progression time wasn't short. It took over a year on average for people to progress either to AML or to low-risk MDS. And if you went back and sequenced that initial non-diagnostic biopsy, you could find clonal hematopoiesis in almost every case, in 91% of these patients. And in general, these patients had high abundance mutations or even high number of mutations. And if you went back and sequenced those patients who had at the time when they had their actual diagnosis made, only 43% had shown any molecular progression, meaning that most of the driver mutations were already in place at that early time point. So these patients obviously were selected because they progressed. So this isn't a perfect study in the sense that we don't know what happened to those patients who didn't progress. But we start to get the idea that there is this spectrum of risk, that if you compare CH.I.P. patients on the left to patients who have frank cytopenias that are otherwise unexplained, to patients that you know progress, you can see that the abundance of mutation goes up, the number of mutations go up, and they start to resemble people who look like MDS at baseline. So there is this idea that having these mutations in unexplained cytopenias is important. So is that enough to say that we should be doing this routinely? So I'd argue that the data that really shows that was presented at ASH this year. There were 2 abstracts that I want to talk about. Neither has been published, so I just have the summary based on the abstracts that were put into the program. The first was from MLL, presented by Wolfgang Kern, where they took over 1,600 patients suspected of having MDS, and many certainly did, and then examined more closely those patients that fell short of that diagnosis. And in this particular case, they were only routinely sequencing 4 genes, that ASXL1, EZH2, RUNX1, and TP53, because they were known to be particularly adverse in the setting of MDS. And they found that about 19% of their patients had such a mutation, so a sizable fraction. And then they asked, what happened to them? They followed them forward. And the really striking thing was that at 2.3 years, the probability of progression was 100%. And at the median time to progression was 14 months. So again, just over a year, with a very high probability of progressing to either MDS or another myeloid neoplasm. Now, for those patients who didn't have one of these 4 mutations, many still progressed, and the time to progression there was much longer. It was 44 months. But again, they didn't look for all mutations. They only looked for mutations in these 4 genes. In the next study, by Luca Malcavati, they looked at 683 patients suspected of having a myeloid neoplasm, and many of them certainly did. But they had a subset, 154 shown in blue here, that fell short of any diagnosis. They had this ICUS condition. And about 37% of them had a mutation, and this time it wasn't in 4 genes, it was in a panel of 42 genes, so a much broader panel. And they asked the same question, and they found that the likelihood of progression was very high. They had about 7.5-fold greater likelihood of progression if a mutation was present, and the probability of progression at 10 years was 96% compared to 15%. Meaning that the absence of mutations was incredibly important as well. So we're doing these tests not only to find those mutations that we think are relevant, but also to show that if you do a broad panel of genes and find no mutations whatsoever, that you're identifying a population of patients who are likely to do well and are likely not to progress. In fact, in this study, they actually looked at some patients who were diagnosed with MDS by morphologic criteria for which they couldn't find a mutation, and not a single one of those patients progressed. So that's useful in the diagnostic idea. There's a few other ways that mutations can be useful if you do a broad panel of genes. I'll just give a couple of quick examples. So this is a mutation profile comparing normal aging on the left to patients who have acquired aplastic anemia, and then patients who have MDS. And you can see that the pattern mutation is quite different. So the finding of a mutation, even though it might be a typical mutation in CH.I.P, like for example, say an ASXL1 mutation, it has different frequencies in different conditions. And in particular, mutations like TP53 that can be found in CH.I.P, are expanded in MDS. So there's a different probability of having one of these conditions when you have a mutation. So certain mutations can be informative that way. But if you actually include non-myeloid mutations in a gene panel, you can actually find things you didn't suspect at all. This is also from an ASH presentation that was later published, looking at patients who had a molecular test done at the Dana-Farber, and many of these patients had known LGL, which is a classic MDS mimic, and many of these patients had mutations in STAT3, this shown here in yellow. Yet there were a number of patients who were not diagnosed with LGL, who were subject to this test, and many of them had mutations in STAT3 as well, and on better diagnostic evaluation were actually found to have LGL indeed and not have MDS, which is what they were suspected of having. And there are a bunch of MDS mimics that can be defined by the mutations that they carry. Here's just an example of some of them. And I have had a couple of examples where a patient has come to me without a clear diagnosis, in some cases after multiple bone marrow biopsies where we've done genetic testing and identified a mutation that really pointed us in a different direction, either to LGL or hairy cell leukemia, for example. And I'll give a couple of anecdotal cases of stuff that I've dealt with in the last 2 months. So these are real cases. I made none of this up. I'll just show you real quick. 71-year-old woman, mild anemia, macrocytosis, mild thrombocytosis, and this had been getting worse and worse and worse over the last 18 months. And she had repeatedly told her outside hematologist she wasn't going to get a bone marrow biopsy. She felt fine. That wasn't for her. She was very anxious about this. So when she came to see me, I said, let's just do the peripheral blood molecular genetic testing, and we found these 3 mutations. So remember, the number of mutations is prognostic, the types of mutations are prognostic, and so is the abundance of mutations. So she had relatively high abundance mutations in SF3B1, very classic for MDS, but also in IDH1 and CBP alpha, which are genes that are more frequently mutated in AML. So I started to get a little bit concerned after seeing this profile. She reluctantly agreed to have the bone marrow biopsy done. Actually, I just shared it with her this week, and she does have MDS RST. So she has a subtype of MDS that fortunately was very low risk. Another patient who was not as upfront about his fear of getting a bone marrow biopsy, an 83-year-old man who had transfusion-dependent thrombocytopenia and an elevated monocyte count. And we scheduled him for bone marrow biopsy on multiple occasions, and every time he'd have an anginal attack and then go to the ER. So we did, after the 3rd time doing that, I said, let's just get the blood test and see what we're dealing with here. And he also had 3 mutations, 2 of them in high-risk genes, ASXL1 and RUNX1, that made me very concerned that he might not have just have CMML, which is what his peripheral blood looked like, but he might actually have something more advanced. And he finally agreed to get to get his biopsy done, and in his case, he had CMML1. So it can be helpful to give you a preview of what you might find. It's certainly not a substitute for a diagnostic evaluation. Another case I want to talk about is also a case that I've dealt with this last month. This is the idea that when you do genetic testing in patients who have cytopenias, you may find things that are not somatic. You might find things that are in the germline. And the number of germline mutations that we've learned about in the last 10 years has grown pretty dramatically. Some of these genes actually have very interesting phenotypes. They don't present in young people. DDX41, for example, when carried in the germline, typically has an age of onset in the 60s. So people you might think of as having more de novo or typical MDS are still at risk of having germline predisposition to this disorder. And in fact, the case that I had this exact mutation. Now, when would you suspect this? If you see a mutation in a gene that can be germline in a patient that you suspect has MDS, and you find it that has a varying allele frequency of about 50%, which is what you would expect for a heterozygous mutation that's present in every single cell, then that might get your suspicions up. If you see biallelic mutations, like 2 RUNX1 mutations or 2 CBP alpha mutations, that might increase the likelihood that one of them is germline. And obviously, if you see younger patients or strong family history, you should consider this as well, but those features don't always need to be present. So in my example, it was a 70-year-old man who came to me with REB2 in a long history of treatment, having no longer responded to hypomethylating agents. We sequenced him to see what else we might be able to offer him, and we actually found just this one mutation in DDX41 with a very high allele frequency. And this is not a benign mutation, it was a truncating mutation that was clearly going to be something that affected the function of the protein. And he had no family history. His age of onset was very high. He was diagnosed when he was in his mid-70s. And we've actually demonstrated that this is germline in him and are sending him to see Lucy Godley, University of Chicago, for further evaluation and counseling. So these things can certainly happen when you do mutation testing. It's something you didn't necessarily anticipate, but it does provide more information that's really relevant, especially if a family member is considering being a donor for a stem cell transplant recipient. So what other value might you have by mutation testing up front at the time when you're trying to establish a diagnosis in a patient with an unexplained cytopenia? Well, one of the major things you can learn about from mutations is if a patient does end up having MDS, we know these mutations are tremendously prognostic. So here's an example where just simply the sheer number of mutations is associated with inferior survival, with the exception of SF3B1, which is actually a favorable mutation. I've isolated that in blue. That's actually better than having no mutations in any of these genes and predicts a much more indolent course. And we can actually refine this a little bit. We can look at it in the context of the IPSSR, where we plot the adjusted risk on the x-axis, so everything to the right of that vertical dotted line is adverse, and everything above the red line is considered significant. And there are 42% of MDS patients who have a mutation in at least one of those adverse genes. And if I didn't show it, but 22% who have an SF3B1 mutation who are better than we predicted. So we can refine prognosis of these mutations quite well, and it's really useful to do this at the beginning when you're thinking about what kind of therapy you're going to use and whether or not you're likely to rush a patient to transplant or maybe wait to see what happens. Finally, there have been other studies that show the importance of mutations with respect to treatment outcomes. So this is a paper that was recently published looking at outcomes after transplantation, where TP53 is particularly adverse. And there's also a paper recently published suggesting that TP53 mutant patients might respond initially really well to a regimen of Decitabine. So again, mutations can influence not only your perception of risk, but actually what you do about it and how you approach them. So the recommendations that I put out today would be that it is useful to obtain a next-generation sequencing-based test, so something sensitive, that looks at many different genes on all patients with otherwise unexplained cytopenias if you plan to do a bone marrow biopsy. In other words, it won't substitute for your regular diagnostic evaluation. This is something you should do to complement that. And the things that you should worry about are that there are certain caveats to interpreting these things. If you find that you have a lot of variants of undetermined significance, those should really be ignored for diagnostic purposes. If you find that only a single mutation with a very low abundance, that is more likely to be background. And if you find mutations that are very, very low abundance, below 2%, they should be ignored outright. And finally, there are a few genes that are really less predictive of progression, as shown in those abstracts. TET2, DNMT3A, ASXL1, and PPM1D. These are more likely to be background mutations and shouldn't, and if there's only a mutation in one of those should be taken with caution. However, multiple mutations with high burden allele frequencies, these are things that should be considered concerning. So unexplained cytopenias are common after biopsy, and they often carry somatic mutations. There are a couple of mutations, SF3B1 in particular, that actually define the disorder, and many that predict progression. And an absence of mutations can be really informative, so it's another reason to perform a test like this. Consider germline variants in patients who you test, and think about the prognostic value that they can offer. So with that, I'll stop here. Thanks.